Good afternoon, everybody, and welcome to Cardiff. So what I plan to present to you over the next half an hour or so is really a culmination of work from over the last 5 years since the International Skin Tear Consensus Panel came to fruition in 2011. And there's been a great deal of work that's gone into looking at prevention, assessment and treatment of skin tears. So I'll be talking to you about how we went about looking at the evidence, and we'll finish up by looking at some pathways that you might be able to implement in practice. So first of all, just to think about who is on the Skin Tear Advisory Panel. Back in 2011, the core group of people were about 11 members, and most of those have remained fairly stable. So there may be a few names on there you recognise: Sharon Baranowski, Diane Langamo. But just to also point out that it's mostly US and Canadian panel members, with at the moment me representing the UK and Europe. So there we go. And that was all because I wrote an article about maintaining skin health. So just watch out what you publish, because it can come back to bite you. But having said that, it's been a very good experience in terms of getting to work across international boundaries. So those 11 members have remained fairly stable. So what we did initially was we looked at what is the size of the problem of skin tears. We talk about skin tears, but actually what is the prevalence of those wounds? And we still find it's very difficult to count the numbers of skin tears, because it's very difficult to do prevalence surveys, and perhaps skin tears are not very well recognised. And like some of the other speakers were talking about earlier today, in terms of undertaking research, how do you go about designing a study that's about measuring prevalence? Because I know certainly one speaker said that she looked at then incidence, because that's more reflective, but that's much more difficult to do. There's also was a lack of a universal definition of skin tears, so that was something that we talked about in one of our first meetings. And classification was also a big issue, so classifying of skin tears, either people not classifying them or using different types of classification systems, and perhaps more complicated systems. So we're going to talk about classification as well. And relatively, the numbers of patients with skin tears is quite small. So again, when you're looking at trying to look at the impact and effectiveness of interventions, when you have small sample sizes, it can be quite challenging. But there are some existing studies that have looked at prevalence, so I'm just going to take you through some of those existing studies. And you can see that most of the studies have been done in long-term care, and there are quite a range of prevalence, between 10 to 42%. So most of those studies, Kim LeBlanc particularly, are based in Canada. There's Curlin Carville and her team are based in Australia. So, and if you look at community settings, you might think, oh, right, okay, so there's not so much of a problem in this community setting. But of course, it's much more difficult, because you're trying to look at prevalence in patients' own homes, which is much more difficult to do. And in acute care, some of the work looking at the prevalence there shows that it's quite low. But in palliative care settings, much higher. But of course, you know, if somebody's at the end of life, then we know they can get skin failure as well. So it's perhaps unsurprising that there's more of a risk of skin tears in those settings. But in paediatric and intensive care setting, prevalence really is much more difficult to count. So what do we know? There's a relatively high prevalence, but it seems to be associated perhaps with more long-term care or more palliative care. So if we wanted to go about doing incidence studies, which is much more difficult to do, looking at the new cases, perhaps in a fairly stable population in long-term care, that may be more straightforward to do. But incidence has shown that perhaps that's between 1.57 and 6.8%. And again, when we look at where the studies have been done, they've been done in Australia and Hiroshi Sanada in Japan. So it's kind of that Pan-Pacific area that seems to have taken much more interest in perhaps in looking at skin tear prevalence and incidence. So a very early estimate of the problem of skin tears has suggested that around 1.9 million institutionalised patients may suffer from skin tears. And more recently, both Curlin Carville and Kim LeBlanc have talked about perhaps that they are more prevalent than pressure ulcers, because perhaps they happen concurrently. And until recently, there's been a lack of information about prevention, assessment and treatment of skin tears. Many skin tears are misdiagnosed and mismanaged, but we know for patients that they have problems of pain, infection, delayed wound healing, and therefore increased cost to the healthcare system. So in the pictures you're seeing here, do we have a pointer? No, probably not. But to the right of the clinical slide on the right of the picture, that was a patient with skin tears that was actually classified as category 2 pressure ulcers. So in terms of getting categories and classification right, of course, we all know the big debate around classifying pressure ulcers. Of course, if we are having other injuries classified incorrectly, then that's going to put your prevalence up of other things as well. So one of the first pieces of work that the International Skin Tear Advisory Panel tried to do was to come up with a definition, having recognised that there's a lack of a universal definition, and trying to recognise that we had to make that different definition stand aside to other definitions of pressure ulcers and so forth. We came up with the definition that skin tear is a wound caused by shear, friction and/or blunt force, resulting in the separation of skin layers. So I think that puts it apart from, if you think about the definition of pressure ulcers that Zena Moore talked about this morning. And also the skin tear can be partial thickness or full thickness. And so you've got examples of different types of skin tears shown there. So what we went on to think about then was, once we had a definition, and believe me, it took more than 2 days, probably, of sitting down and talking about that definition for that little paragraph of words, but trying to come out with the right definition. And I think probably we need to look at how that definition works out there in practice for everybody, because until there's an uptake of the definition and seeing if that actually helps to classify skin tears. So once we had the definition, then what we also went out and did was look at some extensive literature reviews as well to put together the toolkit, which I'm going to talk to you about. So if we look at the hierarchy of evidence in terms of looking at what type of evidence is already out there, we already found out that there weren't many randomised controlled trials for this topic area. Again, it's a difficult area to undertake research in. So what we had to rely on very much was expert opinion, which is seen as ultimately the lowest level of evidence. But I would also put it to you that the new pressure ulcer guidelines, over 500 of the recommendations on there are based on expert opinion, with only 5 RCTs supporting level A evidence for those new pressure ulcer guidelines. So we're kind of on par with the type of evidence that's out there to support practice. So expert opinion can be very valuable in informing guidelines and pathways of care. So what we did in developing the toolkit was we put together some components of the toolkit. So we said, what do we need to be able to assess, manage and treat patients with skin tears? The 11 members of that group helped put together the components of that. And then what we did with the initial toolkit was we sent that out to other healthcare professionals, some of which are in this room, I think, that would have been asked to comment on that toolkit. And that was reviewed by a further 46 experts around the world to just say, would this pathway be useful to you in practice? And what we wanted was a consensus voting. So if any of you have been involved in consensus and Delphi process, what we're looking for is a percentage of agreement that something should or should not be in a pathway. And we were looking for quite a high level of agreement, over 80%. But on all the aspects of the pathway, we got over 98% agreement for those elements. So you can see that it was quite an iterative process to undertake to put together what might seem to you quite a simple pathway when I show it to you. So the toolkit comprises of a number of things. It comprises of a risk assessment pathway, then a decision algorithm about how you treat the patient with a skin tear, and then looking at assessing and treating the skin tear as well. We've introduced the new ISTAP classification system into that toolkit, and we've also suggested a prevalence data collection sheet. You see, we're still talking about prevalence at the moment, which we could debate, but we have suggested how a study might be undertaken for that. We also have some quick reference guidelines on how to reduce risk and the rationale for that care. And then also some additional parts that are in the skin tear toolkit are around what medications can affect the skin and what drugs are associated with risk of falls, because we know that both of those two are quite strong risk factors for skin tears. And then finally, we look at a product selection guide. The table on the right of the screen just shows you the level of evidence and the strength of evidence, and this is what we were trying to base our pathway on. So in summary, the implementation of the toolkit starts with thinking about risk, and we all know there's a big debate around risk assessment and risk scoring, but we've put together quite a simple assessment pathway here that really combines three elements. It asks you to look at the general health of the patient, it asks you to look at their mobility and their skin. So those are three main areas that we're asking to be assessed. And within that general health area, it's thinking about whether the patient has any chronic or critical diseases, whether they've got polypharmacy and they're on lots of medications, and whether there's any impairment either in cognitive, sensory or visual auditory function, and then also thinking about nutritional status of the patient as well. In terms of mobility, there are things in there like history of falls, impaired mobility, dependent on activities of daily living, and also any risks of mechanical trauma. And finally, the skin. So we looked at what are the main risk factors, and that was around extremes of age. So, neonatal skin versus elderly skin, and Dr. George Moncrief talked wonderfully about the changes that happen in elderly skin. So we can already see why there may be problems there. And like with pressure ulcers, in terms of if patients have had a previous skin tear, then that's also a risk factor to consider. So that's the three general areas you're thinking about first of all, and considering whether there's either no risk or some risk. And if there's no risk, it's about reassessing the patient as the condition changes. And then we get on to the risk factors, or the risk score, if you like. It's not really a score as such, but at risk, if the patient has one or more of the risk factors listed above, they're essentially at risk. And then we, from the literature, looked at those factors that are considered high risk. And so from out of that, we've pulled out visual impairment, impaired mobility, dependent on activities of daily living, extremes of age, and previous skin tears. So that any of those puts the patient at high risk. And if that's the case, you implement the risk reduction programme. So the risk factors, which I've tried to summarise here, and remembering these are based on current literature, so these are the most common themes that come out of any of the authors or the publications on what puts patients at risk of skin tears. So the physiological characteristics of the skin that I already mentioned in terms of the neonates where the skin isn't fully matured, and this can be in patients up to the age of 3. So having extreme care, looking after small babies that require lots of acute care, but also skin changes and they're related to critically or chronically ill as well. And again, this was touching on some of the stuff that George Moncrief talked about those changes in the skin that occur, which is why it's so much more at risk. So the dry skin and the advanced age, and he talked about the itchy skin, that itchy scratch itch cycle. So because the skin gets less sebum, less natural moisturisation, it dries out, and then you get mechanical trauma perhaps from itching. And then also you can get decreased sensation as we age as well, which puts more at risk of mechanical trauma. And associated with ageing may be other comorbidities that result in delayed wound healing. There are also other factors related to extremes of age, so senile purpura, seen as bruising, commonly on the forearms, ecchymosis, which is a result of bleeding into the subcutaneous tissue. And I know the next speaker is talking about hematomas, so I'll leave that to him to talk about. And also maybe looking for stellate pseudoscars on the skin, which are thin white scars that you'll often find in elderly patients. And these are just risk factors, again, to show that there's problems with the skin that puts the patient at risk of damaging their skin fairly easily. Other risk factors were being dependent on activities of daily living. So common things are when the patient's being washed, turned, transferred, helped to dress or undress. Damage can happen, unintentionally, but by somebody helping them to do any of those activities. And the patient may also hit themselves on stationary equipment or furniture. But also independent ambulatory patients who are walking around can easily damage themselves if they also have visual impairment. So it's being mindful of those group as well. There's also quite a lot of literature around medications that can affect the skin. And these drugs seem to have a cutaneous or inflammatory interaction or reaction on the skin. And this is not an all-inclusive list. But again, I think it's just thinking of the main groups of medications that your patients may be on that are a risk factor then for thinking about skin changes. And then drugs associated with falls, remembering that falls was another one of the high risk factors for getting a skin or having a skin tear. There's a number of drugs associated with the older population. That means they're more at risk of falls. So as part of the toolkit, it's getting healthcare settings more widely, not just the individual healthcare practitioner, but healthcare settings and services and facilities to think about how they can look at a risk reduction programme. So, we want to prevent these things occurring. So looking at prevalence and incidence and doing some baseline collection of data around what is the problem of skin tears in your setting. And then, in order to collect data on the types of skin tears that are occurring, it's looking at perhaps using a classification system, which I will show to you. And then having a consultative team, so very much multidisciplinary teamwork, because, of course, patients can injure themselves not just on the wards, but when they go off to X-ray or theatres, or just off the wards with their relatives, perhaps. It's being mindful that everybody needs to think about prevention of skin tears. So in terms of the individual level and caregiver level, there's a number of things we can think about which have been summarised in this table for you. So it's about general health issues of educating the patient, providing a safe environment for the patient. Around mobility, I'll just pick out a couple of key things. So thinking about encouraging active involvement, but also choosing the use of devices to assist movement quite carefully. And in terms of the skin, back protective clothing, perhaps moisturising the skin. And on the caregiver side, skin hygiene. And again, picking up on what George Moncrief talked about was around, not using detergents. I think that was a very key message in his talk, if anybody was in there. So how can we do that? Well, that's about maintaining healthy skin is around providing gentle care. That might seem a bit, well, what does that mean? But actually just treating the patient quite carefully and looking at the risk of their skin, using pH-balanced skin cleansers. And Curling Carville's work from 2014 showed that twice-daily moisturisation actually reduced the incidence of skin tears by 50% in their long-term care facilities. So it just shows you how powerful a skin health programme can be. So in terms of assessment and management of skin tears, this diagram sort of summarises really about what we need to do if somebody develops a skin tear. That's around assessing and initially controlling bleeding, cleansing the wound like you would do anyway, approximating the wound edges of the flap where possible, and then using the classification system to classify the type of skin tear. And then we could move on to thinking about the goals of treatment. So just to move on to the classification system, what we did is look at how people were currently classifying skin tears. And we did this back in 2012, but it wasn't published until a few years later. So essentially the key messages out of that were that 70% of respondents said, classification is an issue. It's either because it's too complicated with the current skin tear classification system tools that are in use, or people didn't know how to use them. You didn't know they were available. So people wanted a very simple classification system. So what ISTAP came up with, we looked at the Payne-Martin and the STAR classification that are in use, and we've tried to simplify that into 3 types, essentially type 1, type 2 and type 3, being careful not to cross over with categories, grade, stage, so it gets confused with pressure ulcers. So type 1 skin tears are classified as linear or skin flap flap tear. But the key thing there is the flap can be repositioned, or the wound edges can be opposed and repositioned. So that would be type 1. Whereas in type 2, once you've approximated the skin flap, it doesn't cover the wound bed totally. So you've got some skin flap loss, type 2. And type 3 is where you have complete flap loss. So I would encourage people perhaps to try using the classification system to see if it works for them in practice in helping to classify. I mentioned the prevalence data collection sheet. This is freely available to you if you want to contact any of the ISTAP team. It is written for a US and Canadian population, so it may need some terminology changing, but essentially the key things are there in terms of collecting data on where the skin tear was, what type it is, what was the cause, and where it occurred, and was it a facility acquired or not, or hospital acquired, if you know. So it's along the same lines of trying to collect prevalence data for pressure ulcers, which we would see, hopefully, alongside collecting data on those. Perhaps you could collect data on skin tears as well. And in terms of treatment, again, this is just summarising what we already talked about in terms of the risk factors, but in terms of local wound care, it's about using atraumatic dressings, approximating the edges, addressing any patient-centred concerns. And then what's been incorporated here is the time framework or wound bed preparation, because that's very commonly used by quite a number of healthcare professionals now in treating wounds or assessing wounds. But you'll see the tissue has been, or the T for tissue has been substituted for debridement. So this is dime rather than time, but it's the same framework that you would probably be used to. So that's the idea of assessing the wound as you would any sort of wound. You assess the skin tear using the time framework in order to help you to assess and treat. So the key thing is, once you've cleaned the wound, stop the bleeding, clean the wound, is approximate the wound edges. I know I'm running out a little bit of time, but as a straw poll, going back to the classification system, we had type 1, type 2 or type 3. So can I have hands up for type 1? A bit higher so I can see. Right, okay, and type 2. And this may be type 3 then, I better say as well. So I think all I'm saying there, the classification should work. We've got sort of 80% agreement that that's a type 1. So you can see how perhaps simple it is to use in practice. So once, like you would do with any sort of wound now, and I'm talking to the converted here really, isn't it? It's about thinking about what tissue type you've got in that skin tear. Is the flap viable? Does it need debriding? But of course being careful to debride the wound. So I've got 5 minutes left. Thank you. So we move on to the product selection. Again, this went through a Delphi consensus process. The 11 members initially drew up a whole list of products that they said would be used in the management of skin tears, and we sent that out to colleagues around the world. 105 individuals responded to say what they would use on skin tears. So we were looking for 80% agreement on the products that would be used for skin tear management, and this is available in the 2015 publication. So key things are, in terms of choosing a dressing, it's about moist wound healing, it's about thinking about the local environment, protecting peri-wound skin, managing exudate, but we decided we would avoid use of hydrocolloids, films even, and steri-strips, which maybe we'll come back to. So these are a list of the dressing selections that have been advised to be used as per the consensus agreement. Some of the terminology in here, again, is written for a US, Canadian sort of population of healthcare professionals. But you can see there's a whole range on here of dressings that we would advise should be used, and all of these got at least 80% agreement in the consensus. So in summary, I've whisked you through there, as I say, 5 years of work of looking around classification, assessment, but also providing a toolkit for professionals then to use to provide a holistic approach to the management of an assessment, but also prevention of skin tears for patients. So we think it's applicable to multi-healthcare settings, but we'd like to see it being implemented and used and evaluated. So, we'd really like your feedback on that toolkit. And there is a website which we're currently updating, but it's skintears.org. So most of the resources I've talked about should be available on there. But if they're not, you can send a contact request and somebody will email you with the information. Okay, so thank you very much.